My name's Patty George. I am the co-director of pulmonary hypertension at National Jewish Health in Denver, Colorado. I am also the co-founder of Team Phenomenal Hope, which is a nonprofit endurance team that races to raise awareness about pulmonary hypertension, dedicates our endeavors to elevating patient stories, and raises funds to support research and save patient lives. So today I'd like to talk a little bit about lung transplantation and the importance of organ donation. And I actually went to study pulmonary medicine and pulmonary fellowship at the University of Pittsburgh because of my interest in lung transplantation, and then became a transplant pulmonologist after fellowship, and then was introduced to the world of pulmonary hypertension and evolved into a PH physician out of lung transplantation. So I was always somebody who took care of patients pre and post lung transplant. Now I focus mostly on the pre here at National Jewish Health because we're not a transplant center here. But one thing that I talk about a lot with patients who have pulmonary hypertension, and especially with educating doctors, potential referring physicians to transplant centers, is that obviously pulmonary hypertension is a chronic disease and often progressive disease. And so when patients are starting to get that point where they're on IV therapy, for example, or they haven't responded like we would hope, it's always best to refer somebody earlier rather than later to a transplant center. And for a patient to hear, oh my gosh, I'm being referred for lung transplant, can seem, I'm sure, frankly overwhelming. It's like being hit by a freight train of news in the clinic. But I try to instill in people a little bit of hope in that. And oftentimes when I was at UPMC and seeing patients pre-transplant, we would be seeing people sometimes who were too well for lung transplantation, but they had a lot of smaller issues that we could work on to help make them healthier, such as maybe helping them lose weight or to be a candidate, for example, or get on top of their diabetes or make sure that we treat their osteoporosis, whatever it may be. There's a lot of things that you can do to kind of optimize somebody for lung transplantation. And when you see people earlier, you're given the opportunity to really medically tune them up, make sure they're going to pulmonary rehab, get them as strong as possible, and hopefully make those early interventions. It also allows people, as the patients, to think about this well ahead of when they're really sick. It's better to have frank conversations about what is lung transplant, what is really involved, do I want to go through all this and all the medications and everything they're telling me, do I really want this as my life and lifestyle? It's better to be able to think about that when you're well and can do it around the kitchen table than rather when somebody's sick and in the ICU. And oftentimes, by the time somebody gets to being that sick, it's very difficult if they haven't gone through a transplant evaluation, or even if they have, if they're in the ICU. But if they're in the hospital and they haven't already gone through evaluation, it could be hard to do that evaluation right. And so we would always hope that people would err on the side of an earlier evaluation for a transplant. And then, you know what, if they got better, we would just follow along and sort of, it's something you could put in your back pocket for should the day come when you need a lung transplant. And so it's something I think people should consider in terms of early referrals on the physician side, as well as when patients are referred, not to think it's the end of the world, but just learning about a next possible therapy. Sometimes when patients go to a transplant center for evaluation and they're told they're not sick enough yet for transplant, yet we want to do a transplant before they're too sick, they're left with these mixed messages and it can be quite confusing. So what does that all mean? So we refer to it as physicians, we talk about it as being in the quote transplant window. And what that means is, so lung transplantation, there's a lot to it, and it brings a certain amount of risk. There's a risk of surviving the surgery, and there's a risk of, their long-term mortality. So lung transplant's still a treatment for a disease, not a cure. That's what we would often say to our patients. Now, in reality, if I were to give a PAH patient a double lung transplant, it will cure their pulmonary arterial hypertension. It goes away. It tends to not recur in the new set of lungs. But when we say it's a treatment rather than a cure, what we mean by that is they're exchanging their current disease of pulmonary hypertension for a new condition of lung transplantation. And that brings with it a lot of maintenance, upkeep, and potential risks of infection, rejection. So for somebody to have a new set of lungs that come from another individual, you have to go on anti-rejection medications, which are immune-suppressing medications or immunosuppressive medicines. And so when you go on those, they help prevent the rejection, but they also suppress the immune system and make people susceptible to infections they normally probably wouldn't be affected by. And so people can get pretty sick with infections, whereas normally that doesn't happen. Conversely, despite our best efforts, patients still often will get acute rejection, or the longer they live, the more likely they are to develop an element of chronic lung rejection. And so as that happens, that also can decrease quality of life over time. If that happens to somebody, it makes it challenging. And so the average, median 5-year survival is just over 5 years. Maybe 6. It depends on your disease type. In PAH patients, it's actually better than in other lung diseases. And it depends on the center. So each center has their own median survival. What that means is that half of the people will live longer than that, and half of the people won't make it to that point. So if you have a patient who comes to you and they feel sick and they're on oxygen and they're on 3-drug therapy, but you look at them and you think, man, I think that person has a few years at least living at this existence, and maybe we could do some things to medically optimize them. If you think that they can exist and thrive at least to some degree in their current state, they may not quite yet be in the window. They may still be too well, and you don't want to transplant them too early and potentially shorten their life. That's what we mean by having to be sick enough. Now, conversely, if somebody gets super sick and they're intubated in the ICU, or they've been immobilized for like a month due to some severe infection or whatever it may be, and they no longer can walk down the hallway, for example, then they've become too sick. The risk of them dying in the procedure itself is great. And so that's too sick for transplant. And so we try to find that window where we should list somebody and transplant them so that they're most likely to live the longest and most fruitful, healthiest life post-lung transplant. Organ donation is super important. Even if somebody has pulmonary hypertension, if you check the organ donor box on your driver's license, for example, or make it known that you're an organ donor, they probably won't take the lungs or the heart, given the underlying lung disease, but they may take corneas, or they may find a use for other organs that haven't been affected by disease. Certainly in people who don't have pulmonary hypertension or don't have other diseases, it's really important to be an organ donor. We talked about some of the challenges of lung transplant and the risks, but I'll tell you, when it goes well, it goes really well. And you see people regain their lives, when they've gotten to be so sick, and then they get a lung transplant all of a sudden, and they literally have a second lease on life. There's nothing like it in the world, and that only happens through the grace of other people who've said that it was okay to use their organs after their time's come. So it's important. Hey, I'm Patty George, and I'm aware that I'm rare.